Anyway, it will take a little bit time to start. We need only 2 minutes more, so we can start. Yeah.
Mohammed,
Yes.
what about to start with a company and then I think I don't know the name of the guy. It's from the company, I think.
Dr. Mina Ashraf. Mina.
Yeah.
Yeah.
Why don't we start with him and then medical science side?
If we
Because
do
of the
like,
number of the participants will increase, I think it's not
yeah,
enough participants now.
yeah, there is a lot. They are going to increase. There is
Yeah, but
more than 100 now. Don't count what you are seeing here. We are having another registration. We are having seen another numbers, not what you are seeing only.
okay.
If you want Mina, then that means we will do Fahad that because they are two topics together similar. Then we go to you and then Ayman. You like this? Dr. Ayman, you mind like this?
No, I don't mind at all. Can you, Muhammad, send me the connection on my WhatsApp? I want to send it to my son in UK.
Okay. You mean the invitation? Okay.
The invitation, I want to send it to Dr.
Okay.
Zaid.
Okay. John, okay, I will send it now.
Okay.
John, if you can.
دكتور أيمن، عرفت ابنك، ذكرني اسمه.
شيل الصوت دكتور أيمن، أنت صوتك أيوه أوكي الآن.
Zaid in Leeds. He passed his exam.
الحمد لله. well done. فالآن هو ماشي بالسبيشالست تريننج يعني ها؟
Yeah, he ماشي بالسبيشالست
الحمد لله. والله ألف مبروك، ألف مبروك.
Thank you, Dr. Fahad. Thank you, Habibi. And he came and he did his Jordanian board and he passed his Jordanian board too.
ما شاء الله ما شاء الله.
Good
ربنا يوفق إن شاء الله. والله I'm very happy for him.
Thank you.
لا إن شاء الله we will catch up soon إن شاء الله.
He always speaks very high of you, Dr. Fahad.
لا والله جزاك الله خير يا دكتور أيمن. لا بارك الله فيك. لا and he's a good lad and Leeds are very lucky to have him.
Thank you, sir. Thank you. I hope you and the family are doing well during Ramadan.
والله الحمد لله we all well بس سبحان الله يعني ما في تراويح ما في صلاة.
هو ديروا بالكم باليوكي الوضع صعب I know.
هذا صعب جدا. ما شفت الوالدة والوالدة لي تقريبا 8 أسابيع فصعب شوي لكن الحمد لله يعني العمل ماشي والأولاد مرتاحين فالحمد لله يعني.
الحمد لله يا دكتور فهد. We'd love to see you again my dear friend.
أنجي لا أذكرك التقينا بدبي قبل سنتين ولا لا؟
التقينا قبل سنتين بدبي صحيح.
أيوة لا ذكرتك.
We were presenting دكتور محمد له أفضال دائما ما شاء الله حوله.
أيوة.
الفضل لكم دكتور أيمن، الفضل لك بالعكس أنت أستاذنا الكبير الله يعطيك الصحة.
الله يخليك.
والدكتور فهد لأنه عمره أصغر مني شوي فلذلك أعتبره أخونا الأخ الكبير برضه علما.
ما شاء الله ما شاء الله حوله ما شاء الله حولك يا دكتور محمد. Thank you.
الله يسلمك يعطيك العافية. Now we are going to start. I think we are. Dr. Ayman, I already sent you they will send you to your WhatsApp.
Mohammed, sound is not good. Something is wrong.
Okay, can you hear me now?
Now it's better.
Okay. So I would like to congratulate everybody about on Ramadan, occasion of Ramadan. Today we are on 8th of Ramadan. Ramadan is running very fast. And I would like to welcome my dear friends and teachers and professors, friends Dr. Ayman Midanat, Dr. Ramzi. They are an eminent speakers. Also, my dear friends, brother, Dr. Fahad Kuhail, to participate in this meeting today. Unfortunately, Dr. Atul Kumar have some issue that he cannot join us today. We hope to have him. So our meeting today with Amina. Amina, if you can hear me. I think he is, yeah, Mina.
Yeah. How are you?
Yeah, Mina. Yes, Mina. So they agree all that they want you to start. So it will be our pleasure if you can start your talk. Then Dr. Fahad Kuhail, he will be the second one. Then we will have a discussion. Then after that, we will go to Dr. Ramzi and Dr. Ayman. Please, Dr. Ashraf, you can start, please. Thank you.
Okay, thank you. So I'm just sharing my screen. Perfect. Okay. Good evening, ladies and gentlemen. My name is Mina Ashraf. I'm the marketing director at Lunatus for the Middle East region. Today, we will present to you Preservision 3, which I'm sure you know quite well, which is the rich nutrient support for the management of AMD cases. As you know, the eye is particularly affected by aging, primarily because of its exposure to light. And this is part of the normal aging process. And we can see that with the aging process that happens to the eye, AMD develops. And AMD is associated with three main nutrient deficiencies. First is the oxidative stress and the free radicals, which produce cellular lesions. Second is the low lutein and zeaxanthin levels, which are very important components in the macular pigment, which act as a filter for the harmful blue light. And finally, DHA, docosahexaenoic acid deficiencies, and DHA is found in membranes of the photoreceptor outer segments, and DHA deficiencies are associated with abnormalities in the visual functions. And when we look at the progress of AMD, we see that the exposure to light and oxygen produces free radicals, which produce the oxidative stress, and this produces cellular lesions, and this affects the macular pigment, and this allows the infiltration of the blue light, and hence the accumulation of lipofuscin, formation of drusen's, and formation of AMD. That's why to counteract the progress of AMD, we need to provide the patients with antioxidants to counteract the free radicals, lutein and zeaxanthin to protect the macular pigment and help them perform their role as a filter against the harmful blue light, and finally omega-3 to prevent the accumulation of lipofuscin and the formation of drusen's. And these three classes of nutrients are available in the Preservision 3 formulation. Preservision 3 contains three major classes of nutrients. First is the antioxidants, vitamin C, E, and zinc. Second is lutein and zeaxanthin, which are important components of the macular pigment. Third is the omega-3, and it contains predominantly DHA, not EPA, and docosahexaenoic acid is the type of omega-3 which is proven to help maintain normal visual functions. So we can look briefly on the characteristics of those three different classes of nutrients. Lutein and zeaxanthin, those are dietary carotenoids known as xanthophiles. They cannot be synthesized in the body, but they should be provided by diet, and they are available in leafy green vegetables. Lutein and zeaxanthin are major components of the macular pigment, and the macular pigment is located in a strategic position within the inner retinal layers. It absorbs the blue light prior to reaching the photoreceptors and retinal pigment epithelium, and they have also antioxidant properties. In all studies that studied the patients with AMD, we found that the levels of lutein and zeaxanthin drop down with age and in patients with AMD, and also they were found to be lower in smokers versus non-smokers, and that this suggests why smoking is a risk factor for AMD. In the LUNA study, 108 AMD subjects received a daily supplements of 12 milligrams of lutein and 1 milligram of zeaxanthin for 6 months. The serum levels of lutein and zeaxanthin were increased in all subjects, and the macular pigment optical density increased by 50% in those patients over 6 months, and then they dropped again when they stopped the supplementation. Lutein and zeaxanthin in all the epidemiological studies were shown to reduce the progress of age-related macular degeneration. And in conclusion, epidemiological data indicate that high dietary intake and serum levels of lutein and zeaxanthin are associated with a decreased risk of AMD. And moreover, there is an association between lower levels of macular pigment and higher risk of AMD development. The second class of nutrients provided in the preservation 3 is the vitamins and minerals. First, we have the vitamin C, which has an antioxidant role, even in small amounts. It protects the proteins, lipids, DNA from damage by the free radicals. And second is the vitamin E, which also have an antioxidant role, and it prevents the oxidation of the polyunsaturated fatty acids and phospholipids in membranes. And finally, we have the zinc, which has an essential role in at least 300 enzymes, and it's a cofactor for antioxidant enzymes, superoxide dismutase, and catalase enzymes. And again, in all epidemiological studies, vitamins and minerals were proven to delay the progress of age-related macular degeneration. Finally, omega-3, which is a polyunsaturated fatty acid, it has 3 roles when we talk about AMD. It has a structural role, functional role, and a protective role. Omega-3, and when we talk about omega-3, we are talking specifically about the DHA, the docosahexaenoic acid, which is an essential structural component of the retinal membrane. And the highest body concentration of DHA are found in membranes of photoreceptor outer segments. This is the structural role. And the functional role, DHA rich membranes allows an efficient activation of rhodopsin, which is an essential event in the process of phototransduction. DHA deficiencies are associated with abnormalities in visual function, and their deficits are reversed after dietary DHA in animal studies, and they improve visual functions in preterm and full-term infants. Finally, the protective role of omega-3, the DHA has an anti-apoptic effect on the retina photoreceptor and preservation of mitochondrial functions of the photoreceptors, and they prevent from ischemia reperfusion cell damage in the retina. Also increased acid lipase, they increase the acid lipase lysosomal enzyme activity in the retinal pigment epithelium cells from monkeys fed omega-3 rich diet. So omega-3, by enhancing the acid lipase activity, may reduce the retinal pigment epithelium lipofuscin accumulation. Also, when we look at an overview of the epidemiological studies that studied the effect of omega-3 on AMD, omega-3 fatty acid intake and late AMD, all studies have shown a protective role. Fish intake and early AMD, also all studies show a protective role, and also fish intake with late AMD, a protective role has been proven. So these were the epidemiological data and the theoretical part about the role of lutein, zeaxanthin, the vitamins and minerals, and the docosahexaenoic acid omega-3. So these were epidemiological data. Final section is the interventional studies. We start with the well-known ARIDS study, which studied if antioxidant vitamins and minerals can slow the progression of AMD and AMD-associated vision loss. They studied the 4 categories of AMD patients. And in the ARIDS 1 study, they studied antioxidants, zinc, or zincs and plus antioxidants or placebo. And they found that the highest protective role was in the group that combined antioxidants plus zinc. Antioxidants included vitamin A plus the antioxidant vitamins and zinc, and there was a 19% risk reduction. Risk reduction when they looked at the primary vision outcomes, which is 3 or more fine visual acuity loss. In the progression to advanced AMD, the group that combined antioxidants plus zinc enjoyed a 25% risk reduction in the progress of age-related macular degeneration. So the recommendations of the ARES study is to supplement the patients of intermediate to advanced AMD, but to avoid the beta-carotene, which is vitamin A, because it increased the risk of lung cancer among smokers. And then we come to the AREDS 2, which is a multi-center study that was done in 82 centers. It's a controlled clinical study, and the 82 centers were in the United States. The primary objective was to evaluate the effect of lutein plus zeaxanthin and omega-3 on the progression of advanced AMD. And the secondary objective is to evaluate the effect of eliminating the beta-carotene from the AREDS 1 formula. So they included patients with bilateral large drusen's or bilateral non-foveal geographic atrophy, also included patients with new vascular AMD and central geographic atrophy. They used 4 groups, one group with placebo. It was not a real placebo. It was the AREDS 1 formula versus a group with lutein and zeaxanthin, then another group with omega-3, and finally lutein and zeaxanthin plus omega-3. But here, the omega-3 that they used in the AREDS 2 formula was the EPA-rich omega-3, which was used previously in the cardiovascular studies. So among the 4 groups, there was no difference between the 4 groups, and there was a 30% reduction in the risk of progression to advanced AMD over 5 years with the AREDS 2 formula. And the results showed that the addition of lutein and zeaxanthin or both to the AREDS formula in primary analysis, it did not further reduce the risk of progression, but there was in the secondary analysis a 10% reduction in the risk of progression to advanced AMD with lutein and zeaxanthin. Also, the lutein and zeaxanthin, unlike the beta-carotene, which was used in the AREDS 1 formula, they did not induce the risk of, increase the risk of lung cancer among smokers. However, so the results of the AREDS 2 were positive. It has proven that the AREDS 2 formula can reduce the risk of progression of AMD by 30%, and they proved that lutein and zeaxanthin are a suitable alternative to the beta-carotene, which was used in the AREDS 1 formulation. But one objective was not achieved, which is to show the benefits of the omega-3. First of all, there were some limitations in the AREDS 2 because it was a complicated study that included a secondary randomization, and it may have affected the ability to evaluate the efficacy of lutein and zeaxanthin. There was no true placebo because the placebo arm was actually a control arm with the AREDS 1 formula, and it was designed to detect 25 further reduction compared to the control arm, which was a very ambitious hypothesis. Second, with the AREDS 2 is that the study population were a highly selected group of highly educated and well-nourished patients, and they already had higher plasma and serum levels of lutein and zeaxanthin, DHA, and EPA, and many of them reported taking omega-3 on their own in the placebo group. But the major issue and that's why the omega-3 did not show positive results in the AREDS 2 study, was that the type of omega-3 that was used, it was the EPA-rich omega-3. The ratio of DHA to EPA was in favor of EPA. And this was the case until we came to the NAT2 study, which studied oral docosahexaenoic acid in the prevention of exudative age-related macular degeneration. And here, in the NAT2 study, it was the first prospective randomized clinical study exploring the potential of a long-term 3-year treatment of oral supplement enriched in DHA specifically to prevent the development of AMD. And the objective was to evaluate the efficacy of oral DHA supplementation in preventing exudative age-related macular degeneration. So we compared here 300 patients divided into 2 groups, DHA versus placebo for 3 years. For the time in the primary outcome, there was no difference between DHA and placebo in the time to occurrence of choroidal neovascularization in the study eye. But in the subgroup analysis, the long-term supplementation with DHA dominant omega-3 resulted in 68% reduction in the risk of choroidal neovascularization in patients who had higher DHA, EPA concentrations in their erythrocytes membranes. So in conclusion, for the NAT2 study, the time to occurrence of choroidal neovascularization was similar in the DHA and placebo groups, but choroidal neovascularization incidence was significantly reduced in the DHA supplemented patients, showing a steadily high EPA-DHA level in the red blood cellular membranes. So here in the limitation of the AREDS2, which showed a very good protection from the development of AMD by 30% in the AREDS2 formula, but it did not show the benefit of omega-3. Here in the NAT2, they used the correct type of omega-3 because there are two types of omega-3. The omega-3 that was used in the AREDS2, which is the EPA dominant. This is good for the cardiovascular indications, but for ophthalmic indications, the DHA-rich omega-3 is the correct type because DHA is the major type of omega-3 available in the retinal pigment in the photoreceptor outer layers. So finally, to conclude, Preservision 3 contains the multivitamins or the food supplements that are not synthesized by the body. And these three classes of nutrients should be taken daily in recommended doses for patients with moderate to advanced AMD patients. It contains the DHA and zinc, which help to maintain the normal visual function. And also it has the correct type of omega-3, which is DHA dominant. It has the vitamin C, E, and zinc, which help to protect the cells from the oxidative stress. And also Preservision 3 contains the lutein and zeaxanthin, which are important components in the macular pigment and act as a filter from the harmful blue lights. The directions for use is to use 2 capsules per day as a supplement to be used as part of a diverse, balanced diet and a healthy lifestyle. And this is the formulation of the Preservision 3. Preservision 3 is available in the Middle East markets. And also it's the same product available in Europe in some countries under the name Ocuvite, but here it's under Preservision 3 name. Thank you very much, and I leave the floor for Dr. Muhammad. If there's any questions as well, I'm happy to reply.
Thank you, Dr. Ashraf. Thanks a lot. Appreciate. It's an excellent presentation. Very fluent in English, so I cannot cope with you. Anyway, but a few questions I want to be, as an ophthalmologist, I want to be familiar. When I need to use these medications or this capsule, what is the age? Do we start to prevent, or actually this is a treatment, or it's a help? Because we are having another now, it is only for dry, or only can be used also, because you mentioned also choroidal neovascularization. So we need just to highlight this point very sharply and directly, please.
Yeah, thank you very much for this question. Actually, it has no role in the wet type of AMD. It has a role in the dry AMD. And when I mentioned wet AMD, it delays the progress of the patients from dry age-related macular degeneration to wet AMD. So it's like in patients with dry AMD, it delays the progression to choroidal neovascularization. So it's for dry AMD, and it's proven to protect from the development of wet AMD, but in wet AMD, it cannot help as a treatment. So it's mainly for the dry AMD. For the second question about the use for prevention, in the AREDS2 study, like when we looked at the different categories of patients with age-related macular degeneration, in the patients who had no AMD or early AMD, there was no significant reduction in the progress of AMD, but in the patients with intermediate to advanced, it showed a significant reduction in the progress to age-related macular degeneration. So this is the evidence that we have, but Preservision 3 also has an approved claim for patients starting from the age of 50, especially for those patients who are at high risk because of having some risk factors or patients who have family history. So it also has this approved indication to protect the eyes from aging. So as protective effect. But in the ARIDS study, in the ARIDS 2 study, it was proven beneficial only for intermediate to advanced AMD.
Thank you, Dr. Ashraf. It's an excellence. I have another question, just a very fast and sharp
Muhammad,
answer.
Before you go to your next question, I just wanted to add to Mina's answer. So certainly in the UK, we want to consider vitamin supplements if they have advanced AMD in one eye. So
this is actually, Dr. Fahad, this is a question was sent by one of their colleagues. He's asking, how about selenium, which has a role also as a trace element for AMD patients? So you are going to
I just wanted to add to the original question. So the original question is which kind of patients we should be considering vitamin supplements. I feel if they have advanced AMD in one eye, so they have wet AMD, it's very effective in reducing the risk in the fellow eye. But also if they have advanced AMD in both eyes, so they have wet AMD in both eyes, but their vision is better than 2100, what we found in the ARID studies, if they were on a vitamin supplements, they were less likely to lose more vision. They were less likely to end up with 20/200. So actually, I still give nutrient supplements in my patients with bilateral wet AMD, so long as their vision is good, because we feel that the vitamins or the nutrients have a protective effect. I just wanted to add that point.
Maybe we can have more discussion about this one in the end, because still you didn't present your topics.
Thank you.
I have, is it FDA approved, Ashraf?
Yes, it's available in the United States under the name Preservision ARIDS 2, and in Europe, in some countries as Ocuvite, and in some other countries as Preservision 3. So it is FDA approved, but the FDA approved formula is a little bit different from the formula that we have here in the Middle East market, because we received the Preservision 3 from Europe. So some concentrations of some of the minerals are different because of some differences in the recommended allowances between the US
we are Dr. Ashraf, we are running behind the time, so please can we make the question or the answer as short as possible? Is there a role for prevention tab in polypoidal choroidal vasculopathy? Do you have an idea, or we can direct this question to Dr. Fahad? Dr. Fahad, please.
I think there is a role. So if now, obviously, I would need to look at the ARID study very, very carefully. I don't think they necessarily characterized the type of lesions, but I will have to look at the paper originally. But essentially, I don't make a distinguish. If they have wet AMD, be it PCV or CMV, I definitely recommend these patients to take nutrients to protect the fellow eye.
Okay, Ashraf, how long we should use this type of supplements? For how long? It is a lifelong life when it starts?
Lifelong, and in the ARIDS 2 study, it was for 5 years. So, and it was proven to be very safe.
Okay, so for the time being, I think we can stop here. So now we will go to my dear friend, Dr. Fahad, to present his presentation. Then we can have more further discussion about these topics in the end of this session. Dr. Fahad, please.
Again, I'd like to thank Mohammed for giving me this opportunity and allowing me to share this case with yourselves. My name is Fahad Kure. I'm a consultant ophthalmologist at the Royal Hallamshire Hospital in Sheffield. I'd like to present a case of an 80-year-old female with a presenting complaint of gradual fading of colors, difficulty in seeing writing in low light levels, some of the letters in the words disappearing when reading. She'd undergone bilateral cataract extraction in 2006 with bilateral YAG laser capsulotomy, so her media was very clear, and her visual acuity was 6.9 in the right eye, 6.6 in the left. These were her color fundus photographs. She had healthy optic discs, but as you can see, she has widespread drusen change, these yellow subretinal deposits with some large drusen. And you can look, if you want to work out the size of the drusen, I often compare them to the size of the retinal vein at the margin of the optic nerve. And you can see this drusen here and this drusen there is larger than that. So she has quite a lot of intermediate drusen and some large drusen that are widespread in both eyes. This is her OCT. And if we look at her infrared reflectors, identify some areas of non-foveal involving geographic atrophy, which were not evident in the color photography. And then if you look at her OCT, she has a very thickened Brooks membrane with undulations of the retina.
Fahad, your voice little bit soundy. I don't know. Can you just Can you continue now to see if it's clear or not?
Not at all. With underlying drusen, and there is interruption in the photoreceptor junction there due to geographic atrophy. Is that clearer, Mohammed, or still?
Now very clear. Yes, continue. Thank you.
Thank you. So I'll just repeat this OCT finding. So the OCT shows a thickening of the Brooks membrane with undulation of the RPE due to drusen, but also there's this area of geographic atrophy here, which corresponds to this area here, where there's a loss of the photoreceptor junction with increased transmission of the light. And this is the fellow eye, again with two areas of non-foveal involving geographic atrophy, with drusen evident on the OCT. And this is the autofluorescence. I think this is probably the most useful investigation, particularly for dry age-related macular degeneration. And you can see there's areas of hypoautofluorescence because the RPE is missing in the area of geographic atrophy in both eyes, but also there's increased autofluorescence bilaterally, and that's due to lipofuscin accumulation, which is a hallmark of age-related macular degeneration. And I think autofluorescence is very helpful for me because I think it delineates the areas of geographic atrophy much more clearly, and it's something that you can use as a baseline to monitor the progression of that geographic atrophy over years, over time. So her diagnosis was dry age-related macular degeneration with geographic atrophy, which is also called non-neovascular AMD, which is a US term. She was prescribed an AREDS vitamin supplement because she had advanced AMD in both eyes. So I was concerned that there was a high risk that she would progress. But this patient was a very highly motivated patient. So she was also enrolled onto a trial called the Beacon study, which is an Allergan-sponsored trial, which is looking at the safety and efficacy of brimonidine intravitreal implants in geographic atrophy secondary to age-related macular degeneration. This particular study was looking at a drug called brimonidine, which we use in glaucoma. And it's a selective alpha-2 adrenergic receptor agonist. And what Allergan posed was that because brimonidine is a very effective anti-apoptotic agent, this had treatment benefit in geographic atrophy. So there were two arms to the study. There was an interventional arm where you gave a brimonidine implant through an Ozurdex tile injector. So when we injected these patients, it was like giving an Ozurdex injection, but the implant delivered was a bit smaller, and it obviously had brimonidine in it instead of dexamethasone versus sham injection. And the primary endpoint was the change in the area or the lesion area of geographic atrophy as assessed by autofluorescence at month 24. Unfortunately, the trial was terminated following an interim analysis of 12 months, and that was because it failed to meet its primary endpoint. The termination of the study was not related to the safety factors, and you can imagine that was quite a big disappointment for my patient. So just to remind you, this was her autofluorescence at baseline, and this is her autofluorescence 3 to 4 years later, and you can see there's marked progression of her geographic atrophy. So unfortunately, despite enrollment on the trial, we were unable to retard the progression of her dry AMD, but she has not to this point, over 3 to 4 years of follow-up, developed any wet AMD or neovascular AMD in either eye. So in terms of management of dry AMD, there are no licensed or approved intravitreal therapies for dry AMD at the present, although it's an active area of research. The main area of treatment for dry AMD is supportive treatment and obviously nutrient therapy. And the only landmark trial for dry AMD with proven efficacy is the AREDS trial, which Mina Ashraf very kindly presented earlier. And essentially it demonstrated if they had intermediate AMD or advanced AMD in one eye, and advanced AMD is wet AMD or the presence of geographic atrophy, then consideration of a dietary supplement such as AREDS1 or AREDS2 was recommended. And patients on AREDS supplements had lower rates of AMD progression and moderate vision loss over 5 to 10 year follow-up. And I just want to correct Mina in the sense that if they do have bilateral wet AMD, but their vision is still very good, I would definitely recommend giving these patients dietary supplements because there is evidence that it prevents further moderate vision loss. And there is minimal risk with modest treatment benefit by using these nutrient supplements. But just to labor the point made by Mina, if the individual is currently smoking or is a former smoker, you should avoid beta carotene. And in those patients, the ARES2 formula is more appropriate. So in the UK or in Europe, it's labeled or it's marketed under PreservaVision. This is the original AREDS1 formula, and this is the AREDS2 formula. And in the AREDS1 formula, they had vitamin C, vitamin E, beta carotene, zinc, and copper, but in much higher doses than the patient would be able to ingest through diet alone. But in AREDS2, they substituted beta carotene and they modulated the zinc and added lutein zeaxanthin, as well as some of the omega-3 fatty acids. And just to very quickly, in terms of the results, the patients on the antioxidants and zinc combination had the lowest probability over long term, over 7 years, of developing advanced AMD. So it definitely has a protective effect in those patients who have not yet developed advanced AMD. But if they have developed advanced AMD, it seems to protect that level of vision and preventing further moderate vision loss. But in AREDS2, they wanted to see if the addition of lutein and zeaxanthin or omega acid would have an added protective effect. And as Mina said, there was no real true placebo arm because most of those placebo patients received the original AREDS formula. And although there is some minor favoring of the lutein and zeaxanthin and the omega acid arms, it was not statistically significant. Having said that, I don't use AREDS1 formula in my own practice. I tend to recommend the AREDS2 formula for my patients. So how do you determine which patient will benefit from your recommending AREDS treatment? If they have advanced AMD, those patients, so wet AMD or geographic atrophy, then I would recommend those patients are prescribed AREDS2 to prevent the development of advanced AMD. But if they don't have advanced AMD, then I think it's important to identify the presence of any large drusen or any pigmentary changes in each of the eye. And if you identify large drusen or a pigmentary change, they get a score of 1. And then you add up the various scores in both eyes to get a maximum of 4. And how do you, what is a large drusen? Well, this is an original photograph from the AREDS trial. And this top drusen here is a large drusen. And as you can see, it's greater or equal to the size of that retinal vein. Whilst this smaller drusen here is an intermediate drusen. And here's an eye with 2 risk factors, with large drusen and pigment abnormalities. If you have that in both eyes, then they get a score of 4. And that's helpful because not only can you prognosticate to the patient what their risk is of developing advanced AMD, but also it gives you a trigger for when you should recommend a vitamin supplement, particularly of the AREDS2 formula. So if they have 4 risk factors, then their risk, if they've not had advanced AMD at baseline, of developing AMD at 5 years is 47%. So that really focuses the mind of that patient to monitor at home, to monitor Amsler chart, and to present to you immediately if there's any change or distortion in their vision for anti-VEGF therapy, but also makes it easy to recommend AREDS vitamin supplements to try in that patient to reduce their risk of becoming advanced AMD. Remember, if they have intermediate drusen in both eyes and no large drusen, that's assigned as one risk factor. So to be clear, if they score a risk of 2, then I consider prescribing ARES2 supplement. But if they have advanced AMD, i.e. geographic atrophy or choroidal neovascularization in one eye, then that is a score of 2, and I'm recommending ARES2 automatically to protect the fellow eye and preserving moderate vision in the affected eye, particularly if they're above 20/150. So in summary, there are no approved interventional treatments for dry AMD. However, we can recommend ARES supplements for our patients with intermediate or advanced AMD in one eye. In addition to recommending nutrient supplements, it's important to counsel patients to the importance of good lighting and the use of magnifiers, and advise them to start reading with large print. And it's important that the patient leaves the clinic optimistic, because it's important that you reassure them that their vision loss is often insidious and slow, and that they will still maintain their peripheral vision. Thank you very much for your attention.
Thank you very much, Fahad. It's a great presentation, excellent presentation. I think if there is any question from Dr. Ayman is having a question. Please, Dr. Ayman, go ahead.
Yes. Thank you, Dr. Fahad. It's a very nice presentation. My question is, I usually used to send my patients to the low vision clinic, which sometimes help. But what about the telescopic lenses? Does it have a role in the treatment of such cases?
That's a very, very good question. So there was a phase in the UK where we were using telescopic lenses, and I think it's all patient dependent. There are some patients who get on with it very, very well, and there are some patients who are very, very unhappy. And I, in Sheffield, had to deal with several patients who ended up suing the consultants who implanted those lenses because they were very unhappy. And I just wondered whether they just use more easier means, CCTV means to enlarge print, or magnifiers that they can wear. I would just say be very, very cautious about bringing an implant telescope. There needs to be lots of testing of that patient to make sure they're going to tolerate it afterwards. Otherwise, you're going to have a very unhappy patient who will end up explanting, and I've abandoned referring patients with this type of treatment for those problems.
Thank you, Fahad. I've done 2 cases. The 2 patients are unhappy in spite of the pre-op proper examination for them. They spend hours examining them, and they said both of them fit, but both patients are unhappy, in fact. Thank you very much.
What I would recommend instead is that they wear VR goggles. So there is a company called Iris Vision where you use a Samsung telephone with a VR goggles that allows them to magnify print, to magnify images. That is a much better way, I think, than going down the implantable telescope. But there are some patients where it works really well, but I think it's very difficult to predict, so it's best to avoid, I think.
Totally agree. Thank you, Fahad.
Not at all, shukran.
Any question, Dr. Ramzi, you have any question in this particular field?
Oh, thank you. It's a great talk.
Nina, if you have any question to Dr. Fahad?
I just want to thank Dr. Fahad for the beautiful presentation. I learned a lot from your presentation. I just wanted to make myself a bit clear about the choroidal neovascularization. I meant that it's not a treatment for a wet age.
Okay, I'm with you.
So this is what I meant, but definitely I totally agree with you about protecting the fellow eye and to maintain the vision. Definitely, I agree with you. Thank you. Thank you very much.
Thank you for that clarification.
Thank you.
I think we don't have any other question for the time being regarding the 2 presentations. So it's our time now to go to the surgical side. We will start with my dear colleagues and friends, Dr. Ramzi. Dr. Ramzi, a consultant ophthalmic surgeon, retina macular vitreous disease and surgery, head and founder of Retina Eye Hospital, Bursa, Turkey. Dr. Ramzi, it's our pleasure, and we are proud that you are with us. Thank you for accepting our invitation, and please go ahead. Thank you.
Okay, thank you. Good evening, dear colleague. Before I start my talk, I would like to thank Dr. Mohammed for his kind invitation. It's a great pleasure for me to be a member of this panel and share my experience with you. I have no financial disclosure related with this talk. In my talk today, I will share with you two unique, interesting cases. And the first one is a case with chronic paspalonitis. I think maybe we can put like this here. Yeah. So this is a case with a 90 years old female presented to us with complaints of bilateral severe visual loss in April 2017. And in the past medical history, 9 years ago, the patient has a diagnosis of Behçet disease and received several treatments, as you see on the screen. And during 4 years, after 4 years, she complained about amnesia, some neurologic symptoms, and after neurologic assessment and counsel decide diagnose as neurobehçet and suggest same kind of treatment. And at that time, an ocular examination, best corrected visual acuity was 1 point, anterior segment was quiet, intraocular pressure was normal, but on the posterior segment, there was chronic signs of chronic paspalonitis, dense vitreous condensation, and snow banking, retinal vascularization in both eyes, and proliferation, tractional retinal detachment, combined with exudative retinal detachment. And also on the right eye, there was vascular tumor on the tractional retinal detachment area. So this patient is that time referred one of the good retina uvea specialists in our country, Dr. Tutkun, and she diagnosed this as multiple sclerosis related intermediate uveitis and vasoproliferative tumor, and sent her back to her doctors with treatment recommendation. After that, during 4 years, patient received this treatment, azathioprine and interferon with the principles of multiple sclerosis, and bilateral intravitreal dexamethasone implant, cataract surgery performed on the right eye, and bilateral 4 consecutive sessions of cryotherapy. However, but unfortunately, during these 4 years, the disease got worse and the visual acuity decreased to hand motion on the left eye and 0.16 on the right eye. And the anterior segment on the right eye, there was severe membranes both side of the lens, and which is fundus was not possible to visualize retina, and the left eye anterior segment was quite it's not severe inflammation. So this picture was taken during surgery. It was not possible to visualize retina during examination. So this is dry eye. You see dense hard exudate accumulations and exudative retinal detachment, and also different, several different sizes of vasoproliferative tumor to the inferior and temporal part of the retina. So this is the left eye. As you see, dense vitreous condensation, solitary tumors, several solitary tumors, and tractional detachments. So also the macular edema, as you see on the OCT. So the patient at that period referred to me to evaluate, especially to left eye, in terms of vitreoretinal surgery to save the vision on the left eye, because the doctor assumed that the right eye is inoperable. But since we don't have good experience, such as unique case like diabetic patients, like retinal detachment, therefore, I prefer to operate the right eye first and see the reaction of the eye, the inflammation, then continue to the left eye. And therefore, I operate the first eye, the right eye first. But before operation, apply a megadosteroid therapy to suppress the inflammation. And also after surgery, a few weeks, these megadosteroids continue. So this is the right eye surgery. As you see, severe exudative retinal detachment, exudations, and also the tumors. And after corpitrectomy, first, I plan to finish everything in one surgery to resect all the tumors and do lasers. But then I changed my mind, because if I would do resect all the tumors, all the large retinectomies, and together with severe inflammation, I thought that this would be not good, and I would go phthisis, and there I prefer to do step by surgery, and then only I resect the active part of the tumors. Then I do cryo, double freeze cryo I prefer, and 2 sessions, each sessions like 20 seconds freeze I prefer, and then apply a laser for the feeding vessel, large vessel, then silicone oil tamponades. So 6 months later, I remove the silicone oil. As you see, all the exudates has gone. The retina is so quiet, but then I resect all the necrotic tumor and retina area and the rest of the area, and still there was minimal tractional detachment. But in this time, when the eye is quiet, the inflammation is regressed. I thought that it's the resections is much safer. So after surgery, I gave a gas tamponade, and this picture was taken for 2 week, a month after surgery. As you see, retina is much better than previously, and we compare the perioperative pictures, and all the inferior retinal is attached, and the vision improved to 20/100. And there's still chronic edema on the macular area, but until now there is no recurrence in this patient. So then apply the same kind of surgery to the left eye, just remove all vitreous. Again, in this patient, I do not prefer to resect the tumor, and just after vitrectomy, I just apply double freeze cryo on the tumor. As these are solitary tumors, it's originate from retina, but it's strictly attached to the choroid also. So in such patient, the other way to resect all the tumors, but in this patient also, after this surgery, almost 3 years passed, and still there is the eyes has 20/20 vision. So I also apply a laser to the feeding vessels, and this is 2 months after surgery. As you see, all the tractional is retinal detachment is released, and there's only localized detachment area here is but lasered around that, and tumor is maybe little still a part of the tumor is active, but retina is fine and the macula is okay, and vision is 20/20. So all the patient, all surgical intervention, 2 surgery to the right eye and then 2 surgery to the left eye. First is vitrectomy, cryo, and the lasers, and I apply phaco surgery, and finally apply muscle surgery to correct the deviation of the right eye. And 14 months after the first operation, we obtain stable anterior and posterior segment, and vision improved 20/100 on the right and 20/20 on the left eye. So in conclusion, what I learned from this patient, in such eyes, timing of surgical intervention is very important. We should decide to do surgery before permanent destruction of macula and retina. That's very important. And also pre- and postoperative care is important. We should suppress the inflammation with anti-inflammatory treatment like megadose steroids. And also in such patient, gradual surgical approach, it's important to manage inflammatory reaction. If in this patient, if I on the right eye, if I prefer, if I try to finish everything in one session, I think with large retinectomy and inflammation may cause phthalate bulbi, and the results would not be like this, and we may prefer gradual approach in such patients. So this is the end of my first case. Mohammed, do you think that continue or discuss?
Yeah,
what
we can have one few questions if there is any question regarding to your presentation here.
Ayman?
Just gone to,
yes, Ramzi, thank you very much. This is a very elegant surgery, very interesting cases. I think you've done well because those cases with vasoproliferative retinal tumors and this subretinal exudation, usually the result is not as good, but you have good results. My question is, you said that the patient was diagnosed as intermediate uveitis due to multiple sclerosis.
Yes.
What was the other criteria that was present in this patient to diagnose him like this? Because it looks to me as a vasoproliferative tumors in both eyes?
Actually, I didn't made the diagnosis, Ayman. I didn't follow all of the patients survived, and it was followed by a US specialist, and she made this diagnosis. But the patient has also some neurologic symptoms, but I don't know the laboratory results. Therefore, that's all that I know about the past medical history in this patient.
Thank you, Ramzi.
It's very rare, but I have the odd case of a retinal vasculitis with lots of retinal vascular inflammation, and then they get this very peripheral vasoproliferative tumor. But I agree, the multiple sclerosis, you'd want to see some MRI evidence to confirm that we're dealing with an MS. But it's possible intermediate uveitis giving you a vasoproliferative tumor. I've not seen a case, but I've seen the odd one with very marked retinal vasculitis. And I don't know whether it's the ischemia driving it or whether it's the inflammation that was driving this tumor.
As you know, vasoproliferative tumors is a kind of reactive gliosis.
Yes.
Central nervous system, neurologic tissue do this and aiming to localize the disease in such conditions like trauma, inflammation, or degeneration, ischemia. And we observe these tumors in chronic vasculitis, chronic retinal detachments, Coats disease, retinitis pigmentosa, and also in multiple sclerosis. So these are really chronic disease. And this looks like a kind of reactive gliosis.
Thank you, Dr. Ramzi. Actually, we have a question, live questions. Mr. John, can you open, please, for Dr. Ahmed Al-Barqi? He's having several questions.
Yeah.
Can we have Dr. Ahmed Al-Barqi, please?
Yes. Hello?
Yeah, Dr. Ahmed.
Dr. Ahmed Habib, how are you? Thank you so much for the this gathering, eminent speakers. Thank you, Dr. Ramzi, for from Turkey. It's not a question, I sent it on the chat. Because you said that this vasoproliferative tumor, in the first eye, you tried to resect it, and then in the second eye, you didn't. You decided to do cryo and laser. So my question, just in these query cases, did you send the in the first eye the resected tissue to the histopathology just to confirm the diagnosis and make sure it's just gliosis and nothing more than this?
Not really, because it was not during surgery. It was not possible to obtain a tissue because I resected with eating with vitrectomy probe, doctors, and therefore I did not do that.
Okay, thank you. Okay, thank you so much.
You have any comment, Ahmed? Also, you have a question. Also, you are talking with Dr. Fahad. So if you can also proceed and ask Dr. Fahad, because now you are on live.
For Dr. No, my question was about, this is not a question, it's a comment, because regarding using the brimonidine in age-related macular degeneration, my question was in Bacon study, the duration, this study, how long was the implant stay in the eye?
3 months. So the pharmacokinetics will be 3 months, and you injected them every 3 months. But unfortunately, the trial was ended after a year due to lack of efficacy.
Yeah, that's my question, because it's not expected to last long in the eye because it was not prepared or made at the beginning to be implanted intravitreally. It was just in the conjunctival, just for or intracameral, not into the vitreous, and the bioavailability of the drug differ from if it is put in the aqueous rather than in the vitreous. So that's was my concern about this.
So Allergan did change the formulation a little bit to get a better bioavailability.
Yeah.
And the pharmacokinetics were very good, and it looked very promising, particularly the phase 2. But that's why you've got to do clinical trials. But I just thought I'd share it with you because it was part of the journey for that patient.
Yeah. Thank you so much. Thank you.
No, thank you, Ahmed.
Thank you, Ahmed. We have also Dr. Muhammad Halabia. Can you please open for Dr. Muhammad the mic? Did you open for him, please?
Yes.
Okay. He's there?
I'm waiting for him to accept.
Okay, Muhammad, Dr. Muhammad, who is raising hand. We are having Dr. Zahra Qaddura, also Raima Rashid. So if no, Muhammad is not, we can go to Zahra. Zahra. If not, so maybe we can go to the next case by Dr. Ramzi, and then we can take this name again. Can you inform them, Mr. John, after Dr. Ramzi, so they can be ready to ask the question? Okay, thank you. Dr. Ramzi, please.
Okay, thank you. So this is my case, second case is complex retinal detachment, an atrophic giant macular hole or tear that we will decide together now. So before start my presentation, my patient, what is the complex retinal detachments? So during the last Retina meeting, a colleague from Equator explained complex retinal detachment with these slides. Any eye that had vitreoretinal surgery before with retinal detachment, but we don't know what happened in the first and then subsequent surgery and what we should guess. And many surgeries, silicone oil in and out, and cataract surgery, silicone oil in and anterior chamber, even many times also PFCL bubbles. Surgery done by a general ophthalmologist like that likes retina, but is not a retinal surgeon, and an important amount of vitreous is still inside of the eye, and the posterior hyaloid had not been removed, so even not being removed. So the general mentality is silicone oil solves everything. So this exactly describes my patient that I will present now. This is 62 years old female, referred us with complex retinal detachment and giant macular hole or tear. And in past medical history, 3 years ago, she had cataract surgery, 9 months ago, vitrectomy with silicone tamponade, secondary to retinal detachment, and 1 month ago, silicone oil removal surgery. And a few days after silicone oil removal surgery, retina reattached again. And patient referred to me with these pictures, a severe, almost total retinal detachment with large macular, looks like a tear, and also severe proliferations. So I performed this patient vitrectomy, membranectomy, temporal inverted flap, ILM flap technique, and silicone oil tamponade. And then 3 months later, I removed the silicone oil. So this is the surgery, the patients, as you see here. So is a almost 1,500 microns retinal defect, macular defect. So first I remove the proliferative membrane from the posterior pole. Then I will do fluid air exchange to reattach the retina and aspirate the fluid from the large macular hole. Usually we don't do this, but in this patient, we managed to remove all spinal fluid from aspirating on the optic nerve. Then a piece of bubble, PFCL bubble, and stain the around the macula, and then fill the vitreous with PFCL bubble, and first peel epiretinal membrane under PFCL. I use dual blue with triple blue and brilliant blue. Then I create a crescent of ILM and create a temporal ILM and invert it over the macular hole. And during this period, I pay attention to lay the ILM smoothly as a first single layer to prevent the insertion of ILM into the macular hole. As you know, when the ILM insert into the macular hole, the functional result is not really good. Then go to periphery of the retina and peel membrane. So in this patient, not only proliferation, there are many vitreous on the vitreous base, which compressed vitreous because of silicone oil tamponade. So in such patient, really we pay attention. We should be patient and calm and give time to peel all membrane from the periphery of the retina. Sometimes we need retinectomy, but in my practice, I first pay attention to remove all traction, proliferation, and vitreous, and release the retina as much as possible. If it's not enough, then I do retinectomy. So in such patient, also inflammation is another factor. I do not like to do large retinectomy, but if it's necessary, we should do. So usually I work bimanually, as you see, with forceps and scissors. And for this bimanual work, we need extra light. I use chandelier light, dark chandelier twin light. It's, I think is my experience, it's one of the best chandelier light comparing to other. So there's we did a small retinectomy, then apply laser mainly to the inferior part of the retina. And during this PFCL stay in the eye, it also permanently temporarily attach the ILM over the macular area, then apply silicone oil exchange and fill the vitreous cavity directly, silicone oil PFCL exchange. And this picture was taken 3 months after silicone oil removal. As you see, all the retina is attached, is backla closed. And this is 1 week after first surgery. As you see, the macular hole is flat open, closed. And 3 months after the first surgery, still silicone oil in the eye, as it is completely attached. And this is 2 months after silicone oil removal. You can see a piece of glial proliferation, but macular hole is completely attached. Also, there's a small defect of ellipsoid zone, and vision improved to 2100. So this is the emphasized OCT of pictures of vitreoretinal macular interface. This is ILM peeling area. This is the inverted flap, has little retinal proliferation. You can see the wrinkling. This is dimples of the ILM peeling area. So in conclusion, retinal detachment surgery is not a simple surgery. It requires a certain attention, patient experience, and also temporal inverted flap technique could be the best solution for the treatment of large macular holes as a primary procedure. So this is the end of my talk. Thank you for your attention. So I think if there is a question, I can discuss together.
Thank you, Dr. Ramzi, for an excellent presentation and these two very interesting cases. If there is a question from Dr. Ayman and Dr. Fahad, please, we need to see Dr. Ayman. Can you just stop sharing, please, so they can see all of us?
Okay.
Thank you, Ramzi. This is also an interesting case. I want just to stress again that I've seen cases, as you know, with silicone oil and some heavy fluid mixed in the eye, left and side. You know, I've seen cases with heavy liquid in the anterior chamber. I've seen cases of proliferation, subretinal silicone oil. You know, I stress that these cases are not an easy cases. Retinal surgery needs a specialized person to do it. It's not just if you like the retina, you go ahead and do the vitrectomy. I've been doing vitrectomies for more probably than 28 years now, and sometimes I go to surgery. I said, "Oh my God, why do I gone into this case?" You know, sometimes cases are really difficult. This was a very interesting case. Removal of all fibroses in these cases and traction is very important, as you did. And I usually don't prefer silicone oil in my surgeries, but sometimes you need to do it. You need to put silicone oil. Very elegant surgery. Thank you, Ramzi.
Ayman, I agree with you. For this patient, if there would no large macular hole, I would prefer long-acting gas instead of silicone oil. I prefer silicone oil, especially for macular hole, because we should keep dry the macular area a longer period of time to be able to close. Because it did not close at the first week and the second week. I didn't put the pictures of second and third week. It completely closed almost 2 months after the first surgery. And therefore, in such a large macular hole, I think we need long duration tamponade like silicone oil.
Yeah,
but otherwise, I agree with you. I would prefer gas only for retinal detachments.
Absolutely.
Okay, can you hear me? It's okay. Do you have, Fahad, any question, please?
No, I have no question, just a comment that I really thank you for sharing these very difficult cases. I think what it suggests to a medical retina specialist is that you shouldn't give up on an eye, and if you feel that there is visual potential and the patient would benefit from a vitreoretinal surgery, that you refer it to a specialist, because as you can see, those eyes look to be very difficult, but with meticulous and careful surgery, we managed to get some really good outcomes. Well done.
Thank you, Dr. Ramzi. We are having many questions now. Just first, we will have Dr. Muhammad Salama. Dr. Mr. John, can you open for Dr. Muhammad if he raised hand? Then we will have Dr. Ahmed Al-Barqi again. He wants to comment. Hello?
I'm waiting for him to accept.
Okay. Anyone? Dr. Ahmed Al-Barqi or Dr. Muhammad Salama, he raised hand to ask a question. Meanwhile, we get Dr. Ahmed or Dr. Muhammad. Dr. Ramzi, any systemic workup for the patient to rule out von Hippel-Lindau disease? For the first case, I think.
For the first case?
Yeah.
So clinically, it's not look like. So it's, I think I have many patient cases that I operate resect the tumor for von Hippel-Lindau disease for retinal angioblastoma, but this is really different, Mohammed. There you can see it's very vascularized tumor, but there is no real feeding vessels like von Hippel-Lindau. It's really completely different. I think it's not possible to make a misdiagnosis in such tumor was a proliferative and von Hippel-Lindau. The main reason is the feeding vessels really more large and more exaggerate in von Hippel-Lindau disease.
Excellent, Doctor. Thank you, Dr. Ramzi. It was a question by Dr. Iyad Armoush. We are having another question from one of their colleagues. What kind of tumors the patient had at the end? What was the diagnosis? What do you think is having the tumor?
In the first case, I think.
Yeah, we are talking about the first case. Yeah.
Unfortunately, we did not have a chance to make a histopathologic section because we eat the tumor with vitrectomy probe, and on the second surgery also it was necrotic tissue. There was no active live tumor tissues, but the diagnosis for multiple sclerosis is made with the test and also MRI, I think, because the US specialist that referred the patient to me is Dr. Tutkun. Ignor Tutkun is one of the best US specialists, not only in our country. So she followed the patient and made the diagnosis and referred to me. And the diagnosis of tumor, so there is no other disease that we made a misdiagnosis, as I told you, like von Hippel's and the others, because tumors is typically chronic basis and in detachment exudation area, and therefore we made the diagnosis for as a vasoproliferative tumors. It's clinically. There's no evidence with histopathologic session.
Okay, and also again, how long post-operative you continue steroid? This is a question by Dr. Muhammad Yusuf.
Yeah, for such kind of surgery, if I do surgery and in patient with inflammatory basis, I at least give steroids 4 weeks after surgery, 1 mg/kg per day, then gradually decrease. But the beginning before surgery, I apply megadose steroids, 1 gram prednisolone for 3 days, then continue to do oral steroids during surgery and after surgery, like all in totals like 5 weeks, then continue with topical steroids after 4 weeks.
We have a question from Dr. Hani Ayub. Is there any intravitreal dexamethasone implant post-operatively?
No, I did, but this patient had received intravitreal dexamethasone implant before my surgery, the past medical history, but I did not apply any dexamethasone implant. I just followed this patient almost 3 years now still the patient has 20/100 vision on the right and 20/20 on the left eye. And now we just give 2 times a day topical steroids. And both eyes has cataract surgery. There is no glaucoma problems. Just 2 times a day topical steroids, and the patient still have a very good vision, and there's no recurrence. So I think depends the patient's systemic reaction. Sometimes maybe we can need to give intravitreal injection of steroids, but in this patient, in this lady, we did not need intravitreal steroids, and just topical is enough.
Okay. Also, we are having Dr. Raif email. This, my dear friend, is in Abu Dhabi, a veterinary surgeon. Thank you, Dr. Raif, for being with us. What about doing cryo only without pars plana vitrectomy in the left eye?
In the left eye, actually, the right eye, it's okay, but in the left eye, in the future, the patient may need another surgery when the active tumor is grow, and we may need another surgery, and we may apply tumor resection. But this was the best eye, and again, I didn't prefer to make a complete tumor resection the first surgery, and I apply double freeze cryo. Means first session I apply cryo all the tumors and keep freezing at least 25 seconds. Then the second session, again 25 seconds freeze. So I think this cryo, and I pay attention to freeze all the tumors. But if this tumor is big and the thickness of the tumor is so high, it's not possible to freeze all the tumors. For example, in the left eye, in the lower temporal quadrant, the superior quadrant, the solitary tumors was not completely necrotic because we couldn't make a cryo. But so I keep like this. But maybe in the future she can need if the tumor is progressed. But the main things that here we should apply cryo and double session, double freeze cryo, and try to pay attention to make freeze all the tumors if possible. To make
the question is why
we are having many questions, so we can take now live questions.
Just add on to Dr. Ramzi. So
can I have Dr. Fahad, excuse me, can I have Dr. Raif email? He is on live. Sorry, Dr. Raif, yes, please.
The question is why to do vitrectomy in the first place. I agree with the cryo. The condition is primary and mainly inflammatory, and there's no argument against the double freeze technique. But why to do vitrectomy in the first place, especially that you have to wait for 6 months to do the surgery? Why you didn't initiate with cryo first?
But before the patient referred to me, doctor, the patients for the left eye received 2 times cryo, and they applied cryo and then sent me. And also there was proliferations and tractional detachment on the inferior part of the retina. And not only do vitrectomy for cryo, I also do vitrectomy to release the membranes, and also make a laser around the detachment area. They attach the retina for the inferior part of the retina. So therefore I did vitrectomy, but cryo has been done already before my surgery. Is it clear enough that for your question? But the vitrectomy, why I did vitrectomy.
Yeah, Dr. Raif,
yeah, I mentioned already, and 2 sessions of cryo the patient received before referred to me.
You have any comment, Dr. Raif?
What was the result of the cryo in the before vitrectomy? There was no response to the cryo before, and why did it have response now after vitrectomy?
Actually, there is a few response around the tumor, but the tumors was still active. I think that the cryo was not as effective as I did, and I mentioned. They couldn't do effective cryo at the first, but then the patient, the disease progress, and tractional detachment and the proliferation of membranes develop inferior part of the retina. And I couldn't show all the video, but also the job to clean the membranes, inferior part of the retina, to release the traction, and also attach the retina and do some lasers around the tractional detachment area, extended detachment area.
Okay, thank you, Dr. Ramzi. Thank you, Dr. Raif. We have heard Dr. Ahmed, but we need a very fast because
I just wanted to make a comment. Just with regards to the vasoproliferative tumors of the retina. So as a medical retina specialist, if I don't see a retinal detachment, even if they're large, I tend to give them intravitreal Avastin in the first instance, because in some cases you find it can shrink in size. And then often I will either treat it directly with long duration argon laser burns to try and regress and scar up that vasoproliferative tumor and stop the development of detachment or exudation. And then if that doesn't work, sometimes I consider PDT, and then I might go to cryotherapies. But I've had, just using medical treatment, quite good success in resolving vasoproliferative tumors and preventing any sight-threatening effects on the eye. Sorry, Mohammed.
Thank you, Dr. Fahad, for this. Yeah, it will be an argument also between you and Dr. Ramzi. So we can keep it to the end after Dr. Dr. Ayman. But we have Dr. Ahmed Al-Barki. Please, Ahmed, if you are there.
Yeah.
Yes,
Can you hear me? Yeah.
Yes, we are with you. Yes.
Okay. Thank you, Dr. Ramzi. It was very nice surgery, actually. My question is regarding the second case, which is has recurrent detachment with BVR. Do you think with such kind of patient that you recurrent detachment, so there should be some source of perforation, especially at the periphery, which was not done quite at the beginning of the first surgery. So do you believe that doing in these cases with recurrent detachment, and because whatever you are dissect peripherally, still you cannot, we are not sure 100% that you remove all the vitreous at the periphery, which is a source of perforation. My point here, or I want to listen to your comment, because what I'm doing that in those cases, if you do a larger retinotomy, you will release this traction, and will be, better in the safe side that to avoid any proliferation in the future, because usually when they proliferate, it will proliferate again, because nobody can guarantee that you remove all the vitreous. And one more point, do you believe in using pharmacotherapy to prevent BVR? The simplest one is steroid postoperatively, because I believe it's very useful, especially in young adults.
Okay, thank you for your question and comment also.
We need a very fast answer, please, because we are late. Sorry.
Yeah. So in such patients, I have a big series with the recurrent retinal detachment. First, as I mentioned, I pay attention to release all traction as much as possible. So some case that we need retinectomy. If we need retinectomy, we should do retinectomy as necessary as possible. We should not do retinectomy small area. But in this patient, my point is, I try to release all vitreous membranes through the ora serrata and all around the retina. So if you give time, you can do this. And I have really many cases that I manage with only membranectomy, without retinectomy, because how I decide, when after membranectomy, I fill the vitreous with PFCL. If the retina is released enough, if the retina is perfectly attached, so this is mean that there's no traction, we can live without retinectomy. And in such patients, as I mentioned, usually I prefer long-acting gas like 14% C3F8 instead of silicone oil. I think it's much better tamponade comparing the silicone oil. But first, I prefer to release membrane and vitreous as much as possible. This is my way, but sometimes the other can prefer more retinectomy. But I stay to do retinectomy because of the chronic hypotony and uveitis will be complications. But I do if it's necessary, but usually first try to release with peeling the membrane, the retina, and then if not enough, do retinectomy. And pharmacologic drugs. So I do not believe that there is today any pharmacologic drug that help us to prevent PVR, doctor. And I don't use.
Thank you, Dr. Ramzi. Thank you, Dr. Ahmad, for your comments and your questions. We have questions from Dr. Saad, Dr. Hani, and Dr. Muhammad Imad. So I will ask to take this question later after we finish with Dr. Ayman. So now we will have Dr. Ayman Midanat, Dr. Ayman Midanat, a vitreoretinal surgeon, a well-known figure in the Middle East. Can we have Dr. Ayman? Dr. Ayman, can you go ahead, please? Thank you. Dr. Ayman? Dr. Ayman, are you with us?
Yes, can you hear me now?
Yes, yes, please, go ahead.
Good. All right. Can you see my slide?
Not yet.
Yeah, no?
Can you do share screen, please?
Let me see first. I think, yep. Can you see it now?
Yeah, yes. You just
Okay.
share, yeah. Just open
Okay.
it.
That's fine, great.
Okay.
Good. Now we are on, right?
Yes.
But let me start by this case is a 53-year-old male patient. He presented to our center with a blurring of vision in his right eye, which persists after uneventful phacosurgery done somewhere else.
Dr. Ayman, I cannot, we are seeing only slide, but we are not seeing anything written. Can you enlarge?
You can see my slides?
No, we are seeing only half empty slide.
Let me share again.
You have to stop share, yeah. Okay, you have to open, then.
Let me check again. Let me see.
You can double click on the, yes.
Can you see it now?
Yes, now it's okay. Go ahead, please.
That's
okay.
fine. That's fine.
Just, yes.
Okay.
Yeah.
Right?
Yeah.
Let me repeat again.
Okay.
This is a 53-year-old male patient presented to our center with blurring of vision in his right eye, which persists after uneventful phacosurgery done somewhere else. The patient denied any systemic illness. The right eye examination showed I had motion vision, few scattered KPs, plus 3 cells, the anterior chamber, no synechia. The IOL was in place, pressure was fine, but no fundus view. The ultrasound showed that the retina was flat. The left eye was 0.8. There was few cells in the anterior chamber, also no synechia, but there was a superior temporal retinal hemorrhages, infiltrates, and vascular sheathing. This was the left eye. You can see the infiltrates, the sheathing, the hemorrhages, and the subretinal infiltrates. This is the left eye. This is a photo during surgery of the right eye. In fact, this redness, this congestion is due to the bovidine. The eye was quiet, and there was no fundus view at all. Investigations were done to rule out mainly Behçet disease, sarcoidosis, TB, syphilis, lymphoma. All of this were done, and all of them were negative, except for a slight anemia and neutropenia. We decided to do vitrectomy, diagnostic vitrectomy, and take samples for testing. This was during the vitrectomy. In fact, it was a very dense vitritis in the right eye, and we removed the vitreous, and now we started to have some fundus view, and you can see that there is a lot of infiltrates, superficial hemorrhages in the retina. The vitrectomy was done, samples were taken. Patient was HIV positive. The CD4 cells were 90 and less. He was diagnosed with CMV retinitis, more advanced in his right eye, treated with ganciclovir IV for 4 weeks. Then he was kept on oral ganciclovir. His vision, in fact, postoperatively improved to 0.4 in the right eye. But 4 weeks later, he presented to us like a routine check. When I examined him, there was an inferior detachment in the same eye. And as you know, those patients with CMV retinitis, those detachments are very common, and usually you will find very small holes in the necrotic retina. So another PPV was done to repair the inferior detachment with the small holes. Air fluid exchange, laser PRP was done to the whole retina. It's important to do PRP for the whole of the retina in these cases. Silicone oil air exchange was done. No buckling was needed. This is a view of the right eye after surgery. You see the extensive laser treatment that's been done for the eye. This is the left, this is the right eye postoperatively. And this is the patient after removal of the silicone oil 6 months. The retina was flat. This is the left eye. This is before treatment, this is after treatment. And this is the final outcome. The patient has 0.7 vision in his right eye, and he regained 6.6 vision in his left eye. So the take-home message for this case is that AIDS patients or any immune-compromised patient with CMV retinitis have a high risk of RD. The success rate of treatment is always less than the normal detachment. It's around 65 to 85%. Multiple breaks, which are usually difficult to find, seeking breaks within usually the necrotic retina. Those holes or breaks are usually posteriorly located. The PRP should extend beyond the borders of the break, especially with active CMVR, because of the possible extension of the retinitis to the normal retina and the formation of new breaks. Buckle are usually not necessary, but intraoperative precautions like double gloving, telling your anesthesia colleague that this patient is having AIDS is really necessary. This is the first case. Any question?
Doctor.
Yep.
Can we have Dr. Ramzi, if there is any question to Dr. Ayman about this case?
Yeah, this is great case. It's a really difficult case. Can you hear me, Dr. Ayman?
Oh, yes.
Yeah, we are hearing you. Go ahead, Dr.
This is a very good job. This is a really difficult case. Even some patient, it's not possible to remove the all posterior hyaloid. It's really dangerous. Sometimes I prefer to left the hyaloid attached if it's not possible, because retina is very fragile, as you mentioned. Also, the other things that's just common, usually in such patient, I prefer silicone oil tamponade, as you did. It's better than gas tamponade to keep the retina attached for a long period of time. But also for such patient, it's really important to give correct medical treatment for the suppression of inflammation and the other things. Also, other side of things, that medical treatment of patients is also really important. Good job.
Can we have Dr. Ahmed Al-Barqi, because we have also a question from Dr. Ahmed Al-Barqi. Yes, open the mic for Dr. Ahmed, please.
Hello.
Yes, Dr. Ahmed.
Hello, Dr. Ahmed. How are you?
Dr. Ayman حبيبي وحشني والله كثير. Very good to hear from you and to see you virtually. Yeah, and I hope everything is nice. I heard a very good news about Jordan now, regarding the COVID-19.
Yeah, the epidemic is mostly
best of luck, inshallah. Thank you for your presentation. Very interesting case as usual. I just have two questions just to share with you. You said that at the beginning you did a vitreous sample. So can you tell us the best way to do vitreous sample, how to do it in the best way? And the second point is regarding the intravitreal antiviral like foscarnet and cytomegalovirus retinitis. We actually have some cases use it and it's very effective. Do you use intravitreal because you give it weekly basis for this kind to prevent activity and relapse? Do you have, do you believe in this or you just systemic only?
No, I do. In fact, in this case, we give the patient intravitreal ganciclovir,
implant,
2 milligrams. You can give it every 2 weeks. There is in fact Vitrasert, which can be fixed inside the eye if you want to avoid the systemic complications of the antiviral. It's done by Bush and Lomb. I've never used it. I didn't need it. But what's needed, in fact, in this case, as you know, and I think as Dr. Ramzi said, it's the long treatment, medical treatment. You cannot stop treatment. If you stop treatment, those patients will have recurrences. So this patient was treated, as far as I remember, for 9 months. He was kept on ganciclovir oral for 9 months. So, and you have even to follow them up years after surgery because they might have recurrences.
Okay. Do you have anything, Dr. Ahmed, more?
No, just the best way to do vitreous samples. Just for if you have young doctors joining us or something. So because I know there is some tips and tricks to get a good sample for lab.
Yeah. What I do, in fact, it's as follows. I don't put the 3 trocars. I put only 1 trocar first, and then I go with my vitrector. I cut from the central vitreous, and then I go and then I aspirate from the tube. I remove all the aspirate and I send it for the lab. This is how I do it.
Okay, so you take it in a separate syringe, not from the cassette of the vitrectomy, right?
No, I don't go to the cassette at all.
From the direct syringe.
I take it directly from the tube of the catheter. Yes.
Okay, thank you so much.
Dr. Ramzi, do you have any comment about taking the sample?
So I agree with Dr. Ayman. Do the same things, and before starting to vitrectomy, infusion is closed. Nothing's inside, so I go inside and then take some samples with active aspiration with the syringe from the vitrectomy probe, tubing, then open the infusion and continue. So I do the same.
Okay, I have a question, Dr. Ayman from yes. Any comment, Dr. Ayman?
No.
Okay, I have a question from dear Dr. Muhammad Awdallah. He's saying, very nice case, Dr. Ayman. When's better to do? He's suggesting, is it better to do HIV test as a workup and start patient on a treatment before surgery? Some centers do HIV testing before such surgery. It is also important to take necessary precautions.
Thank you. This is a very, very good question. When I was at the UK doing my fellowship in 91, 92, we used to see a lot of AIDS patients. And in fact, we used to do an AIDS clinic every first Thursday of every month. And we used to see a lot of these CMV retinitis. Nowadays, these cases are rare. We don't see it that much due to AIDS. Although you can see these cases in like bone marrow grafting in immune compromised patients, in patients on chemotherapy, but in AIDS patients, it's not as common as we used to see them. This is why before, it was a routine check. We used to check every patient for AIDS, but not nowadays. Although it's a good idea if you are suspecting CMV retinitis, yes, I think it's a good idea to do checking for AIDS before. In this patients, in fact, CMV retinitis and CMV retinitis, vitritis, dense vitritis, it's not that common. This is why it didn't came directly to our mind.
Okay, Dr. Ayman, thank you. We have Dr. Raif. Dr. Raif, can you go? Yeah, Ahmed is still with us?
Yeah, just one comment. I
Yeah.
remember about the doing vitreous sample. One of the challenge, or not one of the challenge, one of the difficulty you find that because you ask the assistant to aspirate manually from the syringe, and you stop the infusion for sure because you want a pure vitreous sample, not mixed with fluid. So the challenge here is the hypotony, because you need to aspirate 0.1 or 0.2 because you need a big sample for many for the lab. So one of the tricks here, if you instead of to avoid this hypotony, you can switch the infusion to air. So while you are aspirating, you aspirate the vitreous, and if some air bubble come, it will not affect the sample, and it will keep the pressure inside the eye during this taking vitreous sample. So that's one of the trick that you can do, avoid hypotony if you have it, because sometimes the assistant aspirated so fast or so strongly, so you will get sudden hypotony in the eye because the infusion is off. So this is one of the tricks you can
Thank you,
do.
Ahmed, for this, for additional. Okay, thanks a lot. Can we
Mohammed,
have Dr. Yes,
Mohammed, I just have a quick question for Ayman.
yes, please.
As to the ganciclovir implant, I thought it had been discontinued. Is there a generic version of it? The ganciclovir implant.
Well, Fahad, I've never used it. In fact, I know that they existed.
They did exist, yes.
They did exist sometime from, I think, Bush and Lom, but I've never used it. I've seen 3 cases of CMV retinitis all through my life. I've never needed to use an intravitreal implant to treat such cases. In fact.
Okay.
Thank you very much.
Thank you very much, Dr. Ayman. Thanks, Fahad, and Dr. Ramzi. Dr. Raif, I think if he is there, can we have Dr. Raif?
Dr. Ayman, it's always good and informative listening to your presentations, and thank you for sharing this case with us. Great case, thank you.
Thank you, sir. Go ahead.
My question was about initially during your vitrectomy, after clearing out the vitreous, you could see the retinal presentation. It was about severe necrotizing inflammation,
Yes.
whether it be ARN or porn, or again, or CMV retinitis. Why you didn't apply PRP as a prophylactic initially and with silicone oil? That's the usual teaching when we see CMV retinitis or ARN.
In fact, I didn't show it after the vitrectomy. We did laser. We did some laser. We did not do extensive laser. We lasered the necrotic areas. Yes, we did that at the first surgery, but it did not prevent the development of detachment. Thank you for this comment. It's very important comment. Yes, you have to do it whenever you are faced with such a problem. It's advisable to do a proper laser to the necrotic areas. But it was unfortunately, we did not prevent the development of detachment in such cases. This case, in fact.
Thank you, Dr. Raif. You have any other comment before we move?
Thank you.
Thank you, Dr. Raif. Thank you, Dr. Ayman. We have one more question, but we need a very short answer, Dr. Because we are running behind the time. For how long do you continue intravitreal treatment post-surgery?
In fact, between 2 to 4 weeks, you do the intravitreal, or you do the IV antiviral treatment, and then you can go to oral treatment. Now, if you have a recurrence, you can repeat. You can repeat the intravitreal treatment, and you can repeat the IV treatment, of course.
Okay, Dr. Ayman, we can go now to the last case. If you can go very fast.
Yes. No, not this one. We'll go to this one. Can you see my slide?
Not yet.
Yeah.
Yes, okay.
Yes. In fact, this case is among a series of cases of one eye patients with proliferative diabetic eye disease. Most of these cases are have advanced proliferative diabetic retinopathy, and the result after surgery ranged from 6 to counting fingers. But this case was unique. In fact, this is a 60-year-old lady with poorly controlled diabetes, hypertensive, chronic renal failure. She presented with bilateral advanced proliferative diabetic retinopathy. The vision in the right eye was hand motion, and in the left eye was no perception of light. You can see the fundus view. This is the left eye, has no perception of light, and the right eye has hand motion. The patient could see hand movement only temporarily. This is the surgery. The patient has some lens open. I usually remove almost all my patients with proliferative, advanced proliferative eye disease, diabetic proliferative eye disease, because I need to access the periphery of the eye. I need to clean the vitreous from the peripheral retina. This is the fundus. You can see some hemorrhage here, denoting some activity. This patient had Avastin 3 days before surgery. This is an extensive membrane over the posterior pool. This is the site of the optic disc, and this is the site of the macula. This is a small gauge vitrectomy. I use my cutter in most of these cases to remove the membrane. I usually remove most of the membranes using only the cutter. But in this case, in fact, the membrane over the posterior pool and over the macular area was so thick. So we needed to use the scissors. Some of these cases you need to do by manual surgery. But you see that in this case, the membrane, this is the macular area, and the membrane is very thick. My scissors was not great. The retina was very necrotic, very friable. You see that the patient developed a break here easily. He developed the break easily. We did not do any significant traction, but the patient had this break because of the severely necrotic retina. In these cases, I like to, as I said, remove all the vitreous up to the periphery. I like to do laser treatment up to the ora serrata. You see, we managed to remove all the membranes from the posterior pool and the periphery of the retina. Now we are doing proper laser treatment. I'd like to do a proper laser treatment for these cases. I hate to use silicone in general, but in this case, I think the silicone was the best choice because the patient is one eye patient, and there was some activity, and the membrane was thick membrane. So we ended this case by injecting silicone oil inside the eye. First day post-op, the media was clear, the retina was flat, there was few scattered hemorrhages, the vision was counting finger closed. I was happy because whenever the vision improved from perception of light to counting fingers, this is very encouraging. 1 week later, the patient was fine and happy with counting finger half meter and normal intraocular pressure. 2 weeks later, the patient came back complaining of blurry vision in her right eye. Her vision was back to counting finger close. This was her fundal view. You can see this is the disc, there's some hemorrhages, and you can see this yellowish lesion. When I've seen this first, in fact, you know, it's just very unusual, but I thought, well, this is definitely a fibrinous collection over the retina, and this is a fibrinoid syndrome. I haven't seen this since the early 90s, and so it was a bit strange for me to see it 2 weeks post-operatively. So, management, how to manage it? Should I observe? Should I use a tissue plasminogen activator? Should I go ahead, remove the silicone, and then remove the fibrin from the surface of the retina and re-inject the silicone again? What shall I do?
Can we ask Dr. Ramzi about this one? What he will do? If you don't mind, Dr. Ayman, can we ask that?
I can stop here if you like. If you want to ask.
Dr. Ramzi, what do you think? What you will do in this case? Dr. Ramzi, you are there?
Yeah, I'm here. So this is really interesting case, Ayman. I have no single case that fibrinoid syndrome developed 2 weeks after surgery. I don't have any experience. So we observe fibrinoid syndrome just after the surgery, day after surgery, and because of the hemorrhage or exudation and extravasations. And but this is really interesting. 2 weeks after surgery, it's hardly possible to understand what's the reason in this patient. But to prevent this, in my practice, even in case that silicone oil tamponade is used, I use anti-VEGF at the end of surgery. I inject anti-VEGF at the end of surgery into the vitreous cavity, into the silicone oil bubble. So maybe we may use anti-VEGF in such patient that we suspect that like sphere membranes, active membranes, and we suspect that some fibrinoid syndrome will develop, we can use. But in my practice, in diabetic patient, I use anti-VEGF in almost all cases at the end of surgery. Not only before surgery, but at the end of surgery. Maybe this can be another solution to prevent at least. But for this patient, I can suggest to observe this patient with using anti-inflammatory drug like topical steroids, maybe subtenon steroids, and to observe this also to reduce inflammation. Otherwise, not to make surgical intervention.
Okay, what you have done, Dr. Ayman?
Thank you, Ramzi. In fact, I give all my patients pre-op Avastin. I used to give them post-op Avastin. I used to do this. I stopped giving post-operative Avastin probably 3-4 years ago. I have a series of one eye patients with very advanced proliferative eye disease. We've done cases more difficult than this case, and I've never seen it. I used to see a few cases when we started to do vitrectomy for diabetic eye patients in Jordan in 91 and 92, especially with the gas tamponade. But I haven't seen this so many years. This is one. And as you said, if you want to see fibrinoid syndrome, you usually see it the second, third, fourth, the first week post-operatively. During the first week post-op, you see fibrinoid syndrome. You don't see it 2 weeks after surgery. This was a bit strange. The second thing is that the media was clear. The media was not turbid, and the fibrin collection was accumulated in one area. It was not widespread over the whole of the retinal surface. So, any other suggestions regarding treatment?
So I was just going to ask, so I've seen a lot of anterior fibrinoid cases, and in those we've sometimes,
I can't hear you, Fahd.
Oh, sorry.
No,
Can you hear me now?
Yeah, we can hear you. It's
yeah, so I've seen a lot of cases of anterior fibrinoid. I'm really surprised about the posterior fibrinoid. I have to say, I've learned a lot from this particular case. And like Dr. Ramzi, I would probably treat it aggressively with topical steroid. But I think because it's in the retina, I think there's no harm in giving intravitreal TPA and see if it will disperse the fibrin and maybe hasten the visual rehabilitation. And then possibly, if that doesn't work, you then could consider further surgery. But that is a medical retina specialist telling vitreoretinal surgeons what to do. I do apologize.
No.
Thank you
I really appreciate your opinion. I think, yeah, you're right. Tissue plasma is usually useful
Dr. Ayman, your voice is not
in
clear for us.
cases when you have a widespread fibrin retinal surface, especially. Can you hear me now?
Yes, now is better.
Can you hear? Yeah.
Yes, now go ahead.
Tissue plasminogen activator injection is usually useful in some cases if you have a widespread fibrin over the retinal surface and especially if you are using
Dr. Ayman,
air
your
or
voice is also not clear
positively.
now.
Agree.
Your voice,
In this,
yes.
you can hear me now?
Yeah, it's better. So continue in the same way, please.
Yeah, yeah. In this case, in fact, as Ramzi said, I decided to observe. Why do I decided to observe? Because this is a one-eye patient, number one. Her general condition is bad. She's renal failure, hypertensive, everything. Number three is that it's a localized. It's not widespread over the whole of the retina. What I did is I gave her steroid injection. That's it. And I kept her on the steroid drops, and I observed her. This is what I did. And I used to see her every 48 hours, every 2 days, because, you know, she's a one-eye patient. And this is what happened. I'll show you. I did observation. This is 3 weeks post-operatively. This is 1 week after I discovered the case. You can see that the fibrance reaction is less than it used to be. And this is 4 weeks, just by observation only, and giving posterior peribulbar injection of steroid. And the whole of the fibrin was gone, and the vision came back to 1 meter. The patient was
Ayman,
happy. I really was happy, you know.
may I ask a
Yes.
question in that point? So if the
Yeah.
fibrinate plaque would cover the macular area,
Yeah.
not on the outside the macular, if it would be on the macular area, would you do still observe? Would you still observe or do some another way to treat after this experience now?
Yeah. You are making life difficult for me, Ramzi. In fact, well,
Sorry.
Maybe you have an
I
experience
thought
like
this is
this,
a
Dr. Ramzi.
very valid question. In fact, if it was covering just a localized area, even if it was
Yeah.
over the macular area, and the rest of the retina was fine and the media was clear, I would observe too. I
What you will
observed
do,
close.
Dr. Ramzi? Can we have Dr. Ramzi if he's having experience, if it is covering the macula?
No, I don't have such kind of fibrinate syndrome 2 weeks after surgery. I have no single case, but I just make some common try to
How we will do?
find another solution. But I agree with Dr. Ayman. So if it would cover the macular area, I still would prefer to observe with heavy steroid treatment that Ayman did with topical and subtenon retrobulbars, but not to do surgery unless the macular and retinal traction developed. If the
Yeah.
macular and retinal traction developed, in that time, there is no way that we should go inside of the eye, remove silicone oil, remove the plaque, and then give silicone oil again. But unless traction develop, better to observe and with steroid treatment. I think I agree with you with Ayman in such case.
Absolutely. You know, these patients are one-eye patients. You don't want to compromise the eye doing another surgery. But
Ayman, the other things,
yeah.
sorry. So in such patient, I think you don't use anti-VEGF at the end of surgery. That you
No, I
said.
did not. I stopped using anti-VEGF.
But what's the reason why you don't use? What's your hesitations for to give anti-VEGF at the end of surgery into the vitreous cavity? Why don't you use? I really would like to learn your. Maybe you have some experience that I just want to learn. Yeah.
I'll tell you. I stopped because I was not convinced that it's doing anything. You know, after vitrectomy, you know that the half-life of Avastin inside the eye is not that long. The Avastin will not stay inside the eye after vitrectomy, after the vitrectomized eye. This is one. And if you are doing a proper vitrectomy, if you are removing all the membranes, if you are doing a proper laser treatment, I don't find that there is any rule for anti-VEGF immediately after surgery. But if the patient develop any new vascularization in the follow-up period, months, weeks, months later, yes, I do use anti-VEGF, definitely. And I use it in a bigger dose than I use it in unvitrectomized eyes.
So, yeah, my experience, Ayman, so not only for us, also for the participants, anti-VEGF injection at the end of surgery in diabetic patient, if we peel the membrane, we make some retinal defect, not the retinal full thickness defect, but surface defect. And if the patient has a risk of early post-vitreous hemorrhage, my experience, if we use anti-VEGF at the end of surgery, this drug may prevent the risk of early vitreous hemorrhage also, reduce the risk of early vitreous hemorrhage, because anti-VEGF treat the vessels of the walls of the vessels and contract the walls of the vessels and prevent extravasation, prevent rebleeding also, and therefore, actually, in my practice, I use almost in all cases, except only simple vitreous hemorrhage. But in a simple vitreous hemorrhage, if I do laser, again, I use anti-VEGF to prevent macular edema complication. So this is my regular regular setup. After surgery, I use in all cases. Therefore, this is my. Also, there is some study that show they compare the effect of anti-VEGF at the end of surgery and anti-VEGF preventively, which is more effective to reduce early post-vitreous hemorrhage. And in some study on it all report that the anti-VEGF injection at the end of surgery may prevent more effectively early vitreous hemorrhage than comparing the pre-op anti-VEGF injections. So
I'll tell you. Yeah,
can we have Dr. Ramzi the name of this study? And we are running completely behind the time.
Let me just answer Dr. Ramzi.
Very fast.
The anti-VEGF might decrease the vitreous hemorrhage, but in my experience, what makes the vitreous hemorrhage less and less common after vitrectomy is the proper removal of the vitreous up to the pars plana and the PRP that I use up even to the pars plana. I used to indent. If you have time, I can show you. I have the videos. I used to indent the periphery of the retina. I remove all the vitreous up to the trochers, and I do indent also, and I do proper PRP up to the pars plana. In these cases, I noticed that the post-op recurrent vitreous hemorrhage is much less, even when I used to give Avastin post-operatively in the previous years. So there is no clear study to show this, but in my experience, I think is the removal of all of the vitreous up to the trochers and do a proper PRP after surgery is a very valid way to decrease the recurrence of hemorrhage after surgery.
Okay, Dr. Ayman, do you have anything to add in this case? Because we have several questions, we have to answer them.
I want just to, the take-home message is that fibrinosis syndrome is a rare complication of diabetic vitrectomy. It's characterized by fibrin strand formation in the vitreous with condensation of fibrinoid material on the surface of the retina, may develop to turbid vitreous gel and often progressive to retinal detachment with poor prognosis, believed to be due to breakdown of blood retinal barrier, and it's more common in eyes that have undergone vitrectomy with lensectomy or scleral buckling. Observation in the presence of clear media is a valid way of management. Thank you.
Okay. Thank you, Dr. Ayman. This is very, very interesting cases as usual. We are all the time learning from you. Thanks a lot. If you can stop sharing because we have several questions. I think Dr. Ahmed Al-Barqi, one comment to Dr. Ayman, if he is there, and you can open for Dr. Ahmed Al-Barqi. Fast, please. Dr. Ahmed. Okay, before, if there is no...
Hello?
Yes, Dr. Ahmed.
Yeah, sorry, I was waiting to unmute the mics. Thank you, Dr. Ayman, again for your interesting case as usual. Yeah, you mentioned the fibrosis syndrome, which is a rare syndrome. Yes, hardly seen. That I want to just have a comment because there was a study, it's a long time ago actually, discussing this, and they found that this fibroid syndrome can happen starting from 2 days until 14 days. So in this study, they found in 200 eyes, they found this fibroid reaction in 15 eyes. And they found that this reaction start in some eyes 2 days and the other 14 days. So we have a range of time. And as you mentioned in your presentation, that they found a good rule for TPA to be injected before removing the fibrinoid from on the surface of the retina. It will facilitate the adhesion, and also the use in this study aggressive steroid treatment in terms of systemic and topical, and they found that heavy steroid can reverse or preserve the retinal blood barrier, which is the main cause in this disease. That during, as you mentioned, that a lot of surgical trauma, multiple procedure in the same surgery, like lensectomy, buccal, detachment, PRP, all this, if you make it in the same on one surgery in diabetic patient, they have a very negative impact on the blood retinal barrier. So they found that if you use aggressive steroid, it might restore the retinal blood barrier and prevent further accumulation of fibrin. So that's my comment to you. But thank you, very nice case.
Thank you.
Atul Ahmed, this is yeah, I agree totally with what you said, and I want to add to that, patients who have still active disease, patients who have new vascularization in their eye, patients who have poor general health are also more prone to such a complication. Thanks God that it's not common.
I just wanted to add one comment.
Yes,
in the context of a poorly controlled diabetic, it may be prudent to consider local steroid options first, and then only use oral steroid if the local option doesn't improve. Just because when you start a poorly controlled diabetic on steroid, you're going to really cause the hyperglycemia to be out of control, and it may be even that you have to admit that patient for a sliding scale.
Yeah,
thank you.
absolutely. This is definitely a hurdle, and giving systemic steroid to these patients. Those patients usually have general poor condition, and giving them systemic steroid is a risk. In fact,
is a risk. Yeah.
Okay. Thank you, Dr. Ayman. Thank you, Dr. Fahad. We have several questions, but please, if you can give a very short answer because we already exceed our time. This is from Dr. Awadallah to Dr. Ramzi. But do you think it is safe to inject anti-VEGF 3 to 4 days before surgery and once again on the day of surgery? Are you using, I understand from your talk, Dr. Ramzi, you are not giving before. You are giving after.
No,
yeah.
Okay. Let me short answer. In some rare case, I give pre-op anti-VEGF injection 3 to 4 days before surgery, only in case with very active membrane, tractional detachment, also some ischemic retina. So not, so I think not regularly I give injections. It's another job. Ask the patient a few days before surgery to clinic and do injection. Then, so therefore, only few cases I do, but I don't need that. Also, it's necessary in most of the case.
Okay, thank you. We have one question to Dr. Ayman. Do you give the same dose of Avastin, 1.5 milligram or less? I think you talk that you enlarge the dose, but what is the dose you are giving?
You mean post-operatively or
from Sudan, dear
yeah,
friends?
the pre-operative period, I give the usual doses, the 0.5 milligram and 0.5 ml Avastin injection. In cases of vitrectomized eye, I go to from 0.5 to 1 milligram injection. Yes.
I mean, at the end of surgery?
I double the dose.
At the end of surgery? Or
yes,
before?
if you want to give it at the end of the surgery, or if you want to give it in a vitrectomized eye later, 1 week, 2 weeks, I give double the dose, yes.
Okay, double the dose. Okay, some people they are giving every, I mean, 2 weeks instead of giving the same dose, but every 2 weeks. What do you think?
Well, you can theoretically and even clinically, you can give anti-VEGF you can give Avastin every 2 weeks in some cases. There was no harm of giving it.
I think we are having, how about, okay. There is a question I would suspect for Dr. Ayman, this one from Dr. Awadallah. I would suspect fungal infection in such sub-silicon whitish plaque. I have seen that before. This is his comment.
Well, I've never seen a fungal infection in my diabetic cases. I've been doing vitrectomies probably for the last 28 years. I haven't seen it. Although fungal infection, usually you will see a whitish or a yellowish white or a creamy ball in the vitreous cavity, but this was not the case in the case that I presented. Although
Okay.
theoretically, well, it can happen. It can happen. It's part of post-operative infection that can happen.
Okay, we have a question to Dr. Mina. Is it available in Oman?
Actually, in Oman, Preservision 3 is still under registration.
Okay.
So it's not yet marketed in the Omani market.
Okay. There is a question for Dr. Ramzi about the retinal detachment. What was the reason for RD recurrence in your case?
So I saw the patient after retinal detachment recur with severe PVR, but according to me, the reason was the previous vitrectomy. So it is not perfect surgery. I mean, the vitreous base, all the vitreous was full of vitreous still. Therefore, I think the PVR, the proliferation developed. Also, on the lower temporal quadrant, there was retinal defect. And there was some traction of the retinal defect area because of the membranes. I think when the surgeon removed the silicone oil, they did not pay attention to the lower temporal quadrant around the retinal tear. Maybe they should peel the membrane and do some extra laser. But I think they did not do, but I don't know, I just guess.
Okay, we have also a question for Mina, or maybe how long could we use Preserve Vision 3? I think you
long term, yes. And in the ARED study, it was proven to be safe for 5 years. And again, in terms of safety, it does not contain vitamin A, which increased the risk of lung cancer among smokers in the ARED-1 study. So they are replaced by the lutein and zeaxanthin, which are safe for long-term treatment, and they are not associated with an increased risk of lung cancer among smokers. So it is safe.
Another question, Mina, for you also. Is this preservation formula available in UAE suitable for smokers?
Yes, exactly. It is the AREDS2 formula. It is suitable for smokers. The formulas that are not suitable for smokers are the formulas that contain vitamin A or beta carotene, but lutein and zeaxanthin are the suitable supplements for smokers. So Preservision 3 is, yes, suitable for smokers.
Okay, the last question for you is, I asked you this one, but I think they are repeating. Is it FDA approved?
Yes, it is available in the United States under the name Preservision AREDS 2, but in a little bit different formula, because according to the US Pharmacopoeia, there are some recommended daily allowances that are different from the European Pharmacopoeia. So the formula that we have here is the European formula, but yeah, it is the same as the one available in the US, with slight differences in the concentrations of some vitamins.
I don't know, Mr. John, if Dr. Raif email is there. He is still available. He want to talk.
Yes, please.
Yes, Dr. Raif. Sorry to delay you, but we have to take some question here. You have apologized to you. Sorry to keep you. Can you go ahead, please?
It's okay. Thank you, Dr. Ayman, for the very nice exclusive cases presentation. And I would like also to present my comment about if the fibrinoid is in the macular area obstructing the fovea, the center, to inject the TPA intravitreally and then apply a face down position to allow for the silicone oil to displace the fibrinoid into the farther away from the fovea. Thank you.
What's dosage of TPA intravitreal, Dr. Rai? What's dosage?
Well,
it's 50. If it's 50, it's 50 microgram. In fact,
you are reading the same dose.
I'll tell you that the doses for TBA, the doses for TBA is different. When you are giving it is intravitreally, is different from giving it subretinal. When I'm giving it in a subretinal dose, I give it in 12 microgram. Intravitreally, usually we give it in the dose of 25 micrograms. In cases of fibrinoid syndrome, you can increase this up to 50 microgram intravitreally. But to answer my friend, Dr. Raif, in fact, yes, you can use the TBA in the presence of silicone. Yes, if you want to add, the problem of TBA is that it's not available everywhere. What I use, I use the TBA that the cardiac doctors and the vascular doctors are using in the ICU. And it's quite expensive. The vial is 800 JDs, which is equal to 1,200, almost $1,100. So it's not cheap. This is number one. Number two, in fact, regarding the positioning with the presence of the silicone, if you have ever operated in such cases, and I operated on few cases in the early 90s, the fibrin is so thick to the retina, even the presence of the silicone, even if you want to make the patient position, the fibrin will not move because it's very adherent, it's very sticky to the retina. So manipulating the silicone will not be that beneficial.
Thank you, Dr. Ayman. Okay, because actually we are more than 45 minutes, more than the time. But anyway, there is a lot of questions. And I have one question from Dr. Saad Wahib, my dear friend, is a veterinary surgeon in Saudi Arabia. He say about to Dr. Ramzi, but if there was no macular hole, would you adding a scleral buckle be an option in such complicated cases?
Yeah. This is my way. In my practice, I do not use scleral buckle. I rarely use. I first prefer to release the membrane, the retina as much as possible with the peeling the membrane. If it's not necessary, I usually prefer retinectomy, not a scleral buckle, but scleral buckle is another way. So in this patient, the presence of macular hole is not any relation with the scleral buckle indication or not. But usually if there's no macular hole or I do not use scleral buckle. I prefer retinectomy.
Okay. Thank you, Doctor. So I need also a very fast answer from Dr. Ayman, from Dr. Babakar, from a veterinary surgeon in Sudan. What Dr. Ayman think, where is the collection? Is this fibrinode? Is it sub-ILM? Can beating ILM at the time of surgery as a prophylactic tools?
No. This is a very good question. In fact, let me say one thing. I used to peel the ILM in every vitrectomy for proliferative diabetic eye disease. I stopped doing that. I don't peel the ILM except if there is a wrinkling on the macular area, or there is proof during surgery that the ILM is thick, and this might later on be thickened postoperatively. I peel, but I don't peel ILM routinely in my cases. The collection of the fibrin is not sub-ILM, it's over the retinal surface. If you don't remove the ILM, it will be collected over it.
Thank you, Dr. Ayman. The last question is for Dr. Mina. Is it available in Qatar also, Mina? Mina, can you hear me?
No, it's microphone it's mute position.
Okay. Yeah, now we can talk, Mina. Yes.
Yes, I will reply in 30 seconds. Just I will check and get back to you. Just give me half a minute.
Okay. So we will, because we already finished everything. I would like to thank today. Actually, we exceed the time by 1 hour, but because I think we are having a very eminent speakers, and the discussion was very interesting, and the case is very excellent and very mysterious, and it can have many controversies. Thanks for the whole idea that you share with us and your experience, sharing your experience with us. Dr. Ayman, thanks a lot for having you with us. Dr. Ramzi, and we hope to see you also. Dr. Fahad, also this is maybe the third time. So Fahad, you are the owner, you are the one who is having this webinar. But are all the times you are it's my pleasure that you are all the times with us. Dr. Ramzi, we wish to see you also in the future, coming very soon also. Yeah.
With pleasure, with pleasure. I enjoy a lot. Thank you.
We enjoy everything with you.
Question
Yes,
about
Dr.
Qatar. It's not yet registered in Qatar. It's currently available in the United Arab Emirates and in Kuwait. And in the rest of the GCC markets, it is still under registration.
I want to.
There is one comment, Mina, for you. Someone is saying he is having an experience with Bervigen much more than 5 years. That means he is not giving only 5 years.
Yeah, it's for long-term use, exactly. But just the study is the ARIDS 2 study was conducted for 5 years, and there was a follow-up, I think, later. But it is for long-term use. Yes, it's a food supplement, and all the materials are proven to be safe for long-term use.
Okay. Yes. Last.
Dr. Muhammad, can I just say something?
Yes,
I want to thank you very much for inviting me to this very interesting webinar, to see my friends that I haven't seen for quite some time, and to hear some good friends from the audience. So thank you very much. You've been always active, Muhammad.
This is
God
because
bless
I learned that from you. You are our teachers,
God bless you.
And thank you very much, Dr. Ayman, to be with us. Thank you, Dr. Ramzi, Dr. Fahad, Dr. Mina. It was a great. By this, we are going to conclude our session, but we want to just give, we are going to have another meeting next Friday. It will be a very interesting, also with very eminent speakers. And all our now meetings also CME accreditation for our attendees to know. And thanks you for all of you for having you with us and sharing your experience. Thanks a lot and good night. Assalamu alaikum.
Walaikum salam.
Walaikum salam. Thank you. Good night.
Good night.
Good night, Dr. Ramzi.
Good night.
Good night, Dr. Ayman. Mina, good night.
Good night. Thank you very much.
Good night. Thanks a lot.